Thank you. I'll be speaking on this topic of phaco after phakic intraocular lenses. Uh, Most often you come across a situation like this where there's an excellent vault, a very clear lens, a well-centered intraocular lens, a very happy patient. But sometimes you come across these situations where there is a anterior subcapsular opacification, and especially if it impinges onto the central visual axis, it starts impairing vision when you need to take care of this. Some of the factors which promote the occurrence of cataract, if it is just a nuclear sclerotic cataract which can occur in highly myopic patients, obviously it's not the phakic intraocular lens which is at fault. But if it is a low vault, especially if it's less than 250 microns, high myopic patients, if more than minus 15 diopters of patients, and if the age is beyond 40 years, and especially absence of the central port, are considered to be the factors which predisposes to the occurrences of anterior subcapsular cataract. Now that all the imported as well as the Indian phakic intraocular lenses come with a central port, that is a significant step forward in preventing the occurrence of these ASC cataract. But just because the vault is low, that's not considered to be an indication for removal of the lens. You can see this pair of eyes of the same patient followed up by us for about 5 years. Here I think the vault is just about 137 microns. The other eye is just about 84 microns. But you can see the lens is absolutely crystal clear. Obviously, just because the vault is low, you don't have to go ahead and expand these lenses, but follow them up closely just for the semblance of occurrence of an ASC cataract, in which case maybe the lens can be taken out. As far as if at all there is a significant cataract, one of the good advantages of getting a cataract after a phakic intraocular lens compared to a corneal refractive surgery is that there's no alteration in the corneal curvature and there's minimal thickness of the phakic intraocular lens. So basically you can go ahead with your conventional ultrasound or the laser platform, and most often you are dealing with extremes of refractive errors. So Barrett Universal as well as the Barrett toric calculator is the one we use, often using our IOL Master 700 other optical biometers, and it works quite well. No variation as far as the axial length or the curvature is necessary. A typical case, I operated on this case in the year 2012. As you can see, extremely high myope, minus 24 with minus 27. Those days with a significant amount of cylinder. Those days it was not the centraflow that was available. 10 years back, minus 23 was the lens which went inside bilaterally. Developed in the year 2020. This was what the immediate post-operative results was. The patient was quite happy in spite of the significant refractive error that was left over, because much of his, almost the refractive error had come down by almost 20 diopters. But then he did develop a cataract and presented to us bilateral cataract 10 years later. There's some amount of progression of the myopic error compared to what we saw in the immediate post-operative period. But this is the way you take the lens out. Basically, both the Indian lenses as well as the ICL comes out through a 2.4 or even a 2.8 millimeter incision. All I do is to just bring out one of the haptics. It's a 2.8 millimeter incision that I have created in this particular case. And using a hand-over-hand technique, you can bring the lens out, and it easily slips out because of its the collamer material or the hydrophilic acrylic material, which is extremely pliable. The lens can just come out very smoothly, and you can see the ASC cataract that is impinging onto the center, that's causing a drop in the visual acuity. Most often these patients, that was a patient who had a minus 27 diopter power to begin with. This is just it's always a good idea to stain these capsules, because invariably there is anterior subcapsular fibrosis. And when you run into these areas, it's essentially a capsular excess, forceps, the capsular excess, whatever you are convenient, comfortable with. It's important to get an intact capsular excess, because you require a good overlap of the rexis margin over these very soft cataract and these highly myopic eyes. And it's a phaco flip technique that we employ, usually using a high vacuum, but a very low intraocular pressure. Aspiration, it's phaco aspiration that's done. Hardly any phaco power is used. And because of its minus 7 diopter lens, it's a 3-piece intraocular lens that goes inside. You can see that lens power, and that's the lens being slipped in. And exactly the same thing was done in the other eye too. and you can see the result that you achieved in this case after the compared to the phakic intraocular lens. Obviously, intraocular lens takes care of the refractive error even better, but this is not the way to do it in primarily because of the retinal complications that can be associated with it. It's also possible to use a laser platform even in the presence of a phakic intraocular lens, especially because there's a significant anti-subcapsular fibrosis. If you can use the laser, then you get an adequate rhexis, and you are able to exactly titrate the position of the detents in such a way that they overlap onto the anterior lens surface, creating a rhexis. I'm going to skip this. Go forward a little bit. This is what you see is essentially to show that the laser can go through the material of the lens and create an adequate rhexis. It's not a free floating rhexis that you get, but a nice template of the rhexis, and essentially you can go ahead and then do in the conventional manner, create a rhexis of about 5.5 millimeters, and then implant usually a highly myopic lens that goes into the bag, and giving you a fairly good outcome. Let me skip that, and this just to finish off. This is a case I started off with iris clip lenses way back in 2004. The first 3-4 years it was essentially iris clip lenses. Some of these patients are now coming back to me with cataract. As you can see here, it's a nuclear sclerotic cataract, though primarily the lens was not responsible for this. Essentially what you do in this is to create a 5 or a 6 millimeter sclerocorneal incision, because that's the PMMA optic size, and then you disenclavate the haptics as you saw in this particular case, and then you just inject a little bit of viscoelastic. Often the endothelial cell count is already compromised in these cases, so your surgery has to be extremely gentle. And then once you have done that, it's a good idea to suture up this incision and then switch over to your temporal clear corneal incision and do it the phacoemulsification the manner that you are accustomed to. Almost all these cases you are seeing a 3-piece lenses because they are all minus power lenses and essentially being implanted in highly myopic eyes. Thank you so much for your kind attention.